Good morning. So let's get into the next topic, that is preeclampsia. So this is important when it comes to every exam, whether it is your YY exam, whether it is OSMB, whether it's DHA or SMLE or KMLE, everything. This topic is very important, and most of the times questions is asked from this area. So let's get into the topic, preeclampsia. So preeclampsia, reading this will help you to answer almost all questions from your area, this area. So let's get into the topic. This diagnosis. So diagnosis, the hypertensive disorder of pregnancy induced pregnancy include pregnancy induced hypertension and chronic hypertension. So chronic hypertension is elevation of blood pressure before 20 weeks of gestation. If the patient is having hypertension before 20 weeks of gestation, that could mean that the patient is having the high blood pressure recording even before we check the patient. Maybe that was undiagnosed, or maybe the fact that it is diagnosed during the pregnancy. But if it is before 20 weeks of gestation, it is not an pregnancy associated hypertension. Okay, anything after 20 weeks of gestation, we can say that it is because of the pregnancy. So that is pregnancy induced hypertension. During the period of pregnancy or 48 hours after pregnancy, it is considered to be as pregnancy induced hypertension. Okay, so the symptoms like headache, blurred vision, convulsions, and loss of consciousness are sometimes associated with hypertension in pregnancy, but are not necessarily specific to it. Okay, sometimes patients could have symptoms like this. Okay, then diastolic blood pressure is a good indicator of prognosis of the management of hypertensive disorder in pregnancy. So what we need to look more importantly is the diastolic blood pressure. Okay, next thing, if the diastolic blood pressure is 90 mmHg or more on two consecutive reading taken 4 hours or more apart, diagnose hypertension. Okay, if urgent delivery must take place, or if the diastolic blood pressure is 110 mmHg or more, a time interval less than 4 hours is acceptable. Okay, if it is the blood pressure is more than 110 mmHg, the time period that the 4-hour time period, it is okay. If less than interval less than 4 hours is also acceptable. Okay, if hypertension occurs after 20 weeks of gestation during a labor and within 28 hours of pregnancy, it is also already classified as pregnancy induced hypertension. I already told about it. Then if hypertension occurs before 20 weeks of gestation, it is classified as chronic hypertension. That is, diastolic blood pressure alone is an accurate indicator of hypertension in pregnancy. Elevated blood pressure and proteinuria, however, defines preeclampsia. So there are different parts you need to understand here. There are some terms that you need to be familiar with. The first thing is pregnancy induced hypertension. So pregnancy induced hypertension is when the patient is having elevated blood pressures, that is systolic BP more than 90 and diastolic BP, if it is diastolic BP more than 90. So in this case, what we say is that if it is increased, okay, sorry, one second. Okay, if the diastolic BP is increased during the period of pregnancy, like after 20 weeks of gestation, during delivery, and after 48 hours of delivery, then it is considered to be as pregnancy induced hypertension. If the patient is having high BP recording before 20 weeks of gestation, it is considered to be as chronic hypertension. And then we have another term known as preeclampsia. Preeclampsia is when patient have elevated blood pressure, along with that patient have proteinuria. Then we have a term called eclampsia, where patient have severe symptoms. Okay, so the next thing is how the classification is done. Basically we have a table. So this is a very important table. You need to know about this. So we will just go through it. That is, diastolic blood pressure 90 mmHg or more during first 20 weeks of gestation, it is chronic hypertension. 2 reading of diastolic blood pressure, more around 90 to 110 mmHg 4 hours apart, 20 weeks gestation, and no proteinuria, then it's considered to be pregnancy induced hypertension. 2 reading of diastolic blood pressure 90 to 110 mmHg 4 hours apart, 20 weeks gestation, protein urea is present, it is mild preeclampsia. Then diastolic blood pressure 110 mmHg or more after 20 weeks of gestation and proteinuria is present, then it is considered to be as severe preeclampsia. Along with that, the patient should have symptoms like headache, blurred vision, oliguria. Oliguria means passing less than 400 ml per 24 hours. Then upper abdominal pain, epigastric pain or right upper quadrant pain, hyperreflexia, and pulmonary edema. If any of the symptoms is present, we can consider the patient is having severe preeclampsia. And eclampsia is when patient is having convulsions, diastolic blood pressure 90 mmHg or more after 20 weeks of gestation and proteinuria, coma, unconscious or other symptoms and signs of severe preeclampsia. So if there is convulsions, then it is eclampsia. Okay, then we have two other categories, which is mild preeclampsia and severe preeclampsia. I think this is clear for you guys. So if a woman has any one symptoms or sign listed under the severe preeclampsia, pregnancy induced hypertension, there may be no symptoms and only sign may be hypertension. Okay. Okay, so that is about how you classify it. Now we will move on to the next slide. So what are the tests that you do in case of PIH? You do CBC, you can do RFT, you will do urine, then you will do uric acid, you will do LFT, you will do 24-hour urine for creatinine clearance. You will also check for urine protein. Okay. Next is how you manage the cases. Suppose the patient is less than 37 weeks of gestation. If the patient is asymptomatic, twice weekly review HbHc for BP check, fetal monitoring and urine protein. So these three things, BP, the fetal monitoring and urine protein, should be done twice weekly in case of a pregnant woman who is less than 37 weeks. If any of the symptoms is present, or if BP is abnormal, fetal monitoring shows some abnormality, or urine protein, it shows some abnormality, then you would have to refer the patient to a tertiary center. Okay, then you would have to monitor or admit the patient and you would have to observe the patient. Then if outpatient follow-up is not possible, you would have to admit the patient. In that case, after admission, every 4 hours you would have to check the BP of the patient and daily urine protein should be monitored. Okay, this is what is to be done if the patient is less than 37 weeks of gestation. Then, if diastolic BP increases, what is the management that you do? Start treatment with antihypertensives. First drug of choice is labetalol, which is 100 milligram twice daily. Can be increased maximum up to 1200 milligram per 24 hours. To be divided doses, TID or QID doses. Otherwise, you can give methyl dopa 250 milligram three times a day. Maximum doses 2 gram per day. Okay, so this is the antihypertensive drug. That's if the diastolic BP is high, this is a drug that you start giving to the patient. Labetalol, which is 100 milligram twice daily, can be increased up to, according to the blood pressure, maximum up to 1200 milligram per 24 hours divided TID QID doses. And next is methyl dopa 250 milligram thrice daily, maximum dose is 2 gram per day. Okay, now next, if the BP is from the other slide, okay, you don't have to worry about it. Next is BP is not controlled by labetalol and methyl dopa. Next thing is hydralazine, which is 25 to 50 milligram OD. Okay, hydralazine 25 to 50 milligram OD. Still the BP is not controlled. You can add Adalat 20 milligram OD or BD. Okay. Next thing is about labetalol. So this can be asked in case of Viva and all. What is the drug of choice in a pregnant woman? She is having a history of asthma. So in this case, patient first drug of choice, if you say that it is labetalol, then they may ask, the patient is having history of asthma. Can you give labetalol? No, we cannot give labetalol in case of asthma. So in that case, the first drug of choice will be methyl dopa, that is 20 to 50 milligram thrice daily. So in that case, you cannot give labetalol. So the patient is having any history of asthma, heart failure, preferably to be started after 20 weeks of gestation only. So this is the like contraindication to start labetalol. So that is about it. So we can once again see what are the drugs. Drugs are labetalol 100 milligram twice daily. You can increase the dose up to 1200 milligram per 24 hours divided in TID and QID doses, or methyl dopa 250 milligram TID at 3 times a day, maximum dose up to 2 gram per day. Okay. Next is hydralazine 25 to 50 milligram OD. Next is Adalat 20 milligram OD or okay. Uh, Next slide. The science remains unchanged. Keep the woman in hospital. Continue same management and monitor fetal growth and pubic symphysis height. Symphysis-frontal height. If there is signs of growth restriction, consider early delivery. Okay. If not, continue hospitalization until term. If urinary protein level increases, manage as severe preeclampsia. Okay, if protein level increases, you would have to manage the patient as severe preeclampsia. Note signs and symptoms of preeclampsia do not completely disappear under the pregnancy ends. So once again, we have said that gestation age is more than 37 weeks complete. So 37 weeks, up to 37 weeks, we have already said that you have to monitor the patient. Most probably, if the patient is asymptomatic, you can do a PHC visit and then monitor the patient twice weekly and send her back home. And only if she has something abnormal in her BP or her fetal monitoring or anything urine protein is present, in that case only you need to admit the patient. But if the patient is coming after 37 weeks of pregnancy, okay, if the now you need to check the signs of fetal compromise is present or not, decreased amniotic fluid or growth restriction, then you would have to assess the cervix. The cervix is favorable, that is soft, thin, at least 3 centimeter dilated, then you can rupture the membranes with an amniotic hook and induce the labor using oxytocin. You feel that the cervix is unfavorable, that is it is firm, thick and closed, ripen the cervix with prostaglandins or Foley's catheter, or deliver the baby by C-section. These are the options if the patient is more than 37 weeks of gestation. Okay. Now, severe preeclampsia and eclampsia. In this case, severe preeclampsia and eclampsia managed similarly with exception of delivery must be done within 12 hours of onset of convulsions and eclampsia. If the patient have convulsions, then you have to terminate the pregnancy as soon as possible within 12 hours of onset of convulsion. Okay. All cases of severe preeclampsia should be managed actively and preferably in regional tertiary hospital where laboratory facilities and ICU are available. Okay, symptoms and signs of impending eclampsia, that is blurred vision, hyperreflexia, are unreliable and expected management is not recommended. Okay, impending, if there is chance that the patient may go into eclampsia, that is there is blurred vision or hyperreflexia, it's not unreliable because sometimes there could not be some changes but patient can suddenly go into eclampsia. Okay, so in that case, if the patient is having convulsion, you should have that convulsion in mind, that patient may go into the convulsion and all the things should be ready. So you should gather the equipment, that is airway suction, bag and mask, oxygen, and give oxygen 4 to 6 liter per minute if convulsion occur. Protect the woman for injury or do not actively restrain her. Then prepare anticonvulsant drugs. The drugs are, what is the drug that you use in convulsions? That is magnesium sulfate. You know that. So general management, you need to start IV line and infuse fluid. Maintenance load of 80 ml per hour or 1 ml per kg per hour. Okay, and give an anticonvulsant drug after the convulsions. Okay. So first thing, now you have to think that a patient have come and the patient is having convulsions due to eclampsia. So first thing that you will do is position the woman on her left side to reduce the risk of aspiration and secretion, vomit or blood. Then aspirate, this is suction the mouth and throat as necessary, suction, do the suction. Then monitor vital signs, pulse, blood pressure, respiration, reflexes, heart sounds, heart rate hourly. If diastolic blood pressure remain above 110 mmHg, give antihypertensive drugs. Reduce diastolic blood pressure to less than 100 mmHg. If diastolic blood pressure remain above 110, give antihypertensive drugs. Okay, reduce diastolic blood pressure to less than 100 mmHg but not below 90 mmHg. Catheterize the bladder and monitor output and proteinuria. Maintain a strict fluid balance chart. Monitor amount of fluid administered and urine output to prevent fluid outflow. If output is less than 30 ml per hour, you have to withhold magnesium sulfate and infuse IV fluids. Okay, then a normal drinker lactate is fine at 1 liter in 8 hours. Okay, then monitor for development of pulmonary edema. If there is any volume overload, the patient may go into pulmonary edema. Never leave the woman alone. A convulsion following aspiration of vomit may cause death of woman and fetus. Auscultate the lung vases and look for pulmonary edema for rales and crepitations. If crepitations is heard, if it is heard without fluids, and give furosemide 40 mg IV once. Assess clotting status by sending coagulation profile. Okay. Next is all patients with severe preeclampsia and eclampsia should be started on prophylactic anticoagulant therapy. Okay, anticonvulsive drugs. A key factor of anticonvulsive therapy is adequate administration of anticonvulsive drug. Convulsions in hospitalized women are more frequently caused by under-treatment. So you should start magnesium sulfate if the patient is having convulsions without thinking further. So the drug of choice is magnesium sulfate in treating convulsion in severe preeclampsia and eclampsia. All patients with severe preeclampsia plus eclampsia should be managed in regional tertiary hospital only. Intensive care should be given to the patient. So how will you administer magnesium sulfate? So magnesium sulfate schedule for managing the convulsion in preeclampsia and eclampsia is loading dose. You are giving 4 gram of 50% magnesium sulfate solution in dilution IV over 10 to 15 minutes. And maintenance dose is 5 gram of 50% magnesium sulfate solution infusion at rate of 1 gram per hour. Okay, 1 gram per hour, and continue for 24 hours after delivery or the last convulsion, whichever occurs last. Closely monitor the woman for the signs of toxicity before repeat administration. Ensure that respiratory rate is at least 15 per minute. Patellar reflexes are present. Urine output is at least 25 to 30 ml per hour for 4 hours. Withhold or delay drug if respiratory rate falls below 16 per minute, patellar reflexes are absent, urinary output falls below 30 ml per hour or preceding 4 hours. Keep antidote ready in case of respiratory arrest. You know the antidote of magnesium sulfate is calcium gluconate, that is 10 ml 10% over 10 minutes. Slowly calcium gluconate begins antagonize and affect the magnesium sulfate and respiration begins. So this is the most important thing over here. Only thing is this one. This is what will you give, that is a loading dose which is 4 gram of 50% magnesium sulfate solution IV dilution over 10 to 15 minutes, and maintenance of 5 gram of 50% magnesium sulfate solution infusion at rate of 1 gram per hour and continue the treatment over 24 hours after delivery and last convulsion, whichever occurs last. Okay. Next, if magnesium sulfate is not available at your center, only then you would have to think about diazepam. Okay, anticonvulsant diazepam. How will you give diazepam? Diazepam 10 milligram IV slowly over 2 minutes. If convulsion recur, repeat the loading dose. You can repeat it. That is 10 milligram. After that, if the convulsion again occurs further, then you can add a 10 milligram again. Next is maintenance dose. How you add the maintenance dose is 40 milligram in 500 ml normal saline or ringer lactate. Titrate the woman's sedated but reusable. Maternal respiratory depression may occur when the rate exceeds 30 milligram in 1 hour. Assist ventilation, that is bag and mask ventilation, or anesthesia apparatus or intubation. If necessary, do not give more. If necessary, do not give more than 100. Do not give more than 100 milligram in 24 hours. Okay. So this is 10 milligram, then followed by 10 milligram, then 30, 40 milligram in 500 ml. You can give IV fluid as a maintenance. Okay. If convulsions are not controlled within 10 minutes, administer additional 10 milligram more depending upon the size of the woman and clinical response. Be prepared to assist ventilation. Now, antihypertensive drugs, if diastolic blood pressure is 110 mmHg or more, give antihypertensive drugs. The goal is to keep the diastolic blood pressure between 100 and 90. You cannot never reduce below 90. Okay, that will decrease the fetal perfusion. So, prevent cerebral hemorrhage. That is what we need to know. If it is going beyond 110, there is chance for cerebral hemorrhage. So, the drug that we can give is hydralazine. That is 5 to 10 milligram IV. Bolus can be repeated up to 10 to 20 every 10 to 20 minutes. So until BP is less than systolic BP is less than 120 or diastolic BP between 100 90 100 up to 25 milligram you can give. So you can give 5 to 10 up repeated every 10 minutes to 20 minutes. Up to 25 you can give. Okay, up to 25 you can give hydralazine. Next is maintenance dose. Maintenance dose of hydralazine is 40 milligram in 500 ml, same as the other one. 40 milligram in 500 ml Hartmann solution, 4 milligram per hour to maintain the diastolic pressure at 80-90 mmHg. Continuous BP and fetal monitoring and essential as IV bolus can be cause sudden BP fall. Next is labetalol. First thing was hydralazine, next is labetalol. Labetalol is 50 milligram IV, can be repeated every 10 to 20 minutes up to 200 milligram. Maximum dose is 200 milligram. And maintenance dose is 200 milligram in 200 ml of normal saline at 20 milligram per hour. This is easy to remember. 200 milligram in 200 ml of normal saline in 20 milligram per hour. You doubling every 30 minutes. You can double every 30 minutes. You can double the dose if needed. And until the BP is less than 120 or diastolic BP around 90. Maximum dose is 160 milligram per hour. Okay, per hour you can give maximum dose of 160 milligram per hour. Okay, next is nifedipine. Can be added if the BP is not controlled. 20 milligram oral BD. Delivery should takes place as soon as the woman's condition is stabilized. Delaying delivery to increase the fetal maturity will risk the life of both woman and the fetus. Delivery should occur regardless of the gestational age. Okay. In severe preeclampsia, delivery should occur within 24 hours of onset of symptom. In case of eclampsia, they are saying 12 hours. In case of severe preeclampsia, it should be 24 hours of symptoms. In eclampsia, delivery should be within 12 hours of convulsion. Assess the cervix. If the cervix is favorable, we have already discussed about that. The cervix is favorable, then rupture of membrane, amniotic hook can induce the labor with oxytocin. If vaginal delivery is not anticipated within 12 hours or 24 hours, deliver by cesarean section. If the fetal heart abnormality less than 110 and more than 160 per minute, deliver by cesarean section. If fetal heart abnormality is present, that is, if it is less than 110 or more than 160 beats per minute, deliver by cesarean section. If the cervix is unfavorable also, you would have to go for cesarean section. Okay, if cesarean section is performed, ensure that the coagulopathy is ruled out. Avoid pethidine in patients while giving anesthesia. You should give tramal should be considered. Okay. Now, how will you give the postpartum care? Anticonvulsive therapy should be maintained for 24 hours after delivery at least, or the last conversion, whichever occur last. Continue hypertensive therapy as long as diastolic pressure is 110 mmHg or more. Continue to monitor urine output as long as admitted. Follow up at 2 weeks postnatal care with frequent PP reading. So, then anticonvulsive therapy should be maintained for 24 hours, whichever occur last. If the delivery happened last, then after 24 hour after delivery. If conversion occurred last, then conversion from the time of conversion, 24 hours. Continue antihypertensive therapy as long as the diastolic pressure is 110 mmHg or more. Continue to monitor urine output as long as admitted. Follow up at 2 weeks postnatal with the frequent BP reading. Then if BP were normal, patient can be referred back to the primary care center. If BP reading was abnormal, continue BP monitoring till 6 weeks in PNC visit. The woman with persisting hypertension and proteinuria in 6 weeks may have renal disease and should be referred to the physician. Now, when you refer the patient in a tertiary care center, consider refer the women who have severe preeclampsia and eclampsia. The last two divisions. The patient who have mild preeclampsia is okay, but severe preeclampsia to eclampsia, where the patient is having symptoms, where the patient is having convulsions. In that case, you have to refer the patient to a tertiary care center. Then oliguria that persists for 48 hours after delivery. In that case, you have to refer the patient to the tertiary care center. Coagulation failure, coagulopathy, hemolysis, elevated liver enzyme, low platelet, persistent coma leading to conversion. Then chronic hypertension. Again, in case of chronic hypertension, what you need is encourage the patient to have rest. Then high level of blood pressure, maintain renal and placental suffusion in chronic hypertension. Reduced blood pressure will result in diminished perfusion. So you should never lower the blood pressure before, like, less than the pre-pregnancy level. So there is no aggressive treatment will help the perfusion, or the maternal will not improve the maternal or the fetal outcome. So if the woman was on an antihypertensive medication before pregnancy, then and the disease was well controlled, then you can continue the same medication if it is acceptable in pregnancy. If diastolic blood pressure is more than 110 or systolic blood pressure is more than 160, treat with antihypertensive drugs. If proteinuria or other signs are present, consider superimposed preeclampsia or managed as mild preeclampsia. Monitor fetal growth and condition. If there is no complication, deliver them. If preeclampsia develop, manage as mild preeclampsia or severe. If the fetal heart abnormality is present, if it is less than 110 or more than 160, you would have to suspect fetal distress. And if fetal growth restriction is present and pregnancy detecting is accurate, assess the cervix and consider delivery. So that is about the eclampsia. It is a important chapter, but still it is comparatively an easy chapter as well. So thank you so much once again. Be familiar with the doses of treating the magnesium sulfate dose, the dose of the drugs that you are giving, the labetalol dose, hydralazine dose, methyl dopa dose. All this will be asked in case of PIVA. So, and the things that you will monitor, and when you will do the delivery, what is the weeks, that is a 37 weeks thing. So these are the important factors that you need to know in case of in case of preeclampsia. Now we will next video we will discuss the questions in preeclampsia. Thank you.